Hi guys, today we will try to talk something about some practical facts regarding hand and forearm examination. But first of all, I would like to say a few things, and the first thing is that situation I encourage you to stay home, and this little movie will be also available for English students and also for Romanian students. Why is that? Because I think that English language it's very good and it's enough for all of us to understand this kind of explanations. Also, after you will view this little movie, I would suggest you to try to write some questions on an email that I will provide you at the end of this movie. Also, if you have questions regarding the burn session, I mean the burn lecture, which I'm sure that you already read on the online platform of our university, please write them also on the email I will provide to you. I also encourage you to read everything you find and everything you need regarding plastic surgery on internet. Try to read everything, try to find articles, try to find movies, try to find pictures, try to find explanations regarding all the stuff you have to learn this semester, not only plastic surgery, of course, until we will provide and we'll set up some video live sessions on our web platform. We will keep going with these PDF materials on the online platform, and also we will try to provide more and more video sessions with kind of practical explanations. Today we will start talking about hand trauma, but first of all, in this session we will try to get to learn some skills about hand and forearm examination, regarding also the anatomy of this part of the body. In order to understand the examination of the hand, we have to know some basics about anatomy and the basics of hand and forearm examination. Of course, like other parts of the body, the hand and forearm examination, it's based on inspection, palpation, and percussion. To the inspection and all of this stuff, we have to do it bilateral, with the both hands of the patient put it on a table, an examination table, right here, and like that, both hands on the patient. And what we can observe the structure of the skin, the potential deformities, congenital or after trauma, and other things, starting to wounds, excoriations, and, as I said, deformities and other abnormal position of the hand and of the forearm. Regarding the anatomic layers of the hand and forearm, we have to start with inspection of the skin and of the nails. So, as we know, the skin of the dorsal aspect of the hand is different from the anterior aspect of the hand. On the posterior aspect of the hand, we have the skin which is almost present, the characteristics are almost present, and most parts of the body. So here we have tiny skin, we have hair, and we can observe the relief of the bones, of the extensor tendons, and of the joints, metacarpophalangeal joints, interphalangeal joints, proximal and distal interphalangeal joints. We can observe the color of the skin. We can observe the hair on the skin, and also the veins, the superficial vein system, which drainage the blood from the hand. Now, on the anterior part of the hand, we can observe that the laxity of the skin is almost absent. We cannot pinch the skin. The skin is very attached to the internal structures of the hand. It's attached through these creases of the palm, or the creases of the interphalangeal joints, and we can also observe the fingertips. We have the fingerprints here, which are unique for individuals and which are used in identifying the person in the forensic medicine and criminology. And also these creases and these fingerprints have the role of prehension, of adhesion, and it's an ancestral genetical structure of this kind of skin. We also can observe this type of these characteristics of the skin also in the plantar region at the level of the foot. So regarding the skin, we can observe if there are any kind of wounds, new one or old ones, scars. We can observe also the color, the pilosity at the inspection, and also the structure of the fingernails. If through the skin there are some deformities of the osteoarticular system or aponeurotic palmar system. It is also very important to see if the color is the same on the same hand or the same of the both hands. We also can observe through the inspection through the skin if the structures as tenar region or hypotenar region are equal on each hand. Regarding the bone structure of the hand and also of the forearm, we can see at the inspection if there are some deformities with or without wounds. These deformities means basically fractures or the trauma of the joints, like luxations or displacement. We can observe also congenital deformities, and also we can observe if there are some other deformities regarding to chronic rheumatic diseases, such as rheumatic arthritis, or if we have the contraction of the palmar aponeurosis, which is called Dupuytren disease, which we will talk about later in other practice sessions. This is a chronic pathology. And also we can observe if we have a good flexion of the digits, a good extension of the digits. I mean active extension or active flexion, which patient can do when we demand it. We can demand to the patient, okay, now let's do the flexion of the fingers and do the extension of the fingers, and we can observe if these movements are normal or there are lack of these movements through to all the fingers or to a specific one. For example, if a patient will have a section of the fifth digit flexor tendon, then the aspect will be like this, because the extensor apparatus will pull the digit in the extension, so we will have a position like this and not like this. So we can corroborate this thing, this aspect of the inspection with the presence of a wound around here or at the level of the forearm, and we can see if there is a new wound or an old wound or a scar at this level of the forearm or of the hand, and this position, for example, we can see for the first time starting to inspection that that patient might have a section of the flexor tendons of the fifth digit. This is only an example of the value of the inspection. Now, regarding the bone tissue, we can also see, as I said before, deformities of the level of the bones. But for that, we have to know and we have to repeat, and you will have to repeat harder at home the anatomy of the hand and of the forearm. Now we can see, as we will see a little bit later in some presentation, that as we know, at the level of the forearm, we have two main bones, the radius and the ulnar, and there are a lot of other bones at the level of the hand. What is also important is the anatomic position of the hand. As we know and as we learned in the first year of faculty, the normal position of the upper limb is like this, with palm regarding in the front of us. So this is the anatomical position. We have the anterior side of the upper limb. We have the posterior side of the upper limb. We have the medial side of the upper limb, or ulnar side of the upper limb, and we have the lateral side of the upper limb, or radial side of the upper limb. And also we can talk about digits. Here, for example, we have the medial part of the digit, the lateral part, or radial side, or ulnar side or radial side of it. So this is the anatomical position of the hand, as you already know. Okay, now when we talk about some basics about anatomy, and now we will talk something about bones and about to make the examination of the skeletal system. Now, I would like to thank to my colleagues and our colleagues and students from Student Surgery Society of Romania, Craiova branch, because of this presentation. So now, we have some elements to discuss. First, bones, joints, muscles, blood supply of the hand, and nerve of the hand. Now, the skeleton, about 27 bones around. We have carpian bones, metacarpal bones, and phalanx. So we have carpian, which are this projection on a surface anatomy. Now we have metacarpal around here, and we can see them or palpate them on the dorsal of the hand. And of course, phalanx. We have on each digits, the digits from 2nd to 5, we have 3 phalanx, proximal, intermediate, and distal phalanx. And the level of the pollicis of the thumb, we have 2 phalanx, proximal and distal phalanx. And here we have the first metacarpal bone, because we have the anatomic position of the hand. We have digit 1, and we have the first digit, second digit, third digit, fourth digit, fifth digit. Now, the carp, we have 8 carpal bones. We have proximal level and distal level. And we have scaphoid, semilunatis, pyramidal, pisiform, and the distal we have starting from the radial side or lateral side to the medial side. have this bones, another four bones, trapeze, trapezoid, capitate, hamate. But anyway, as I told you, you should follow and review very well the anatomy at home. So don't forget to stay home. So now, the most important trauma at the level of the hand are regarding the bones are the fracture of the metacarpal bones and phalanx. Fracture or dislocation of carpal bones and carpal joints are not so often. And how can we manage this kind of how do we examine it? First of all, as I told you, the inspection we can see some irregularities or some deformation of the bones. We can see edema of the soft tissues, and at the palpation, unfortunately, I don't have any help, any assistant to show you the palpation. As I told you, we have the both hand, yes, both hand on the table, on the examination table, and we have to palpate each bone to see if we observe any irregularities, any crepitations, or any pain. And if there is a fracture somewhere, we can palpate the irregularity of the bone, and we can observe, and the patient will tell us that the palpation in the fracture zone, he can claim pain, an acute pain called fixed pain. În română este durere în punct fix, care este specifică fracturilor oaselor din orice zonă. Deci la palpare avem irregularități pe care le putem simți chiar și prin edemul părților moi și putem simți la palparea în zona focalului de fractură crepitații și pacientul acuză durere în punct fix. It is very important not to dislocate more than it's necessary, and the fractures, especially if they are new, because we can aggravate them. Deci este foarte important ca în momentul palpării să nu încercăm neapărat să facem manevre prea agresive, deoarece în fracturi complicate, proaspete, putem să agravăm fractura și chiar putem crea leziuni de structuri de vecinătate, cum sunt vasele și nervii. So it's very important to carefully examine the bone and manipulate the bone, not to aggravate the fracture, and more than that, because of the fracture, not to provoke lesions of the other structures around the bone, like blood vessels or nerves. Now, we will pass these slides with the metacarpal bones. Now we see the phalanx, as I told you. We see also the joints here, so we'll go back, and we can see here the metacarpophalangeal joints. We can see here the proximal interphalangeal joints, and here the distal interphalangeal joints. Okay, these are the joints. So we have the carpal system. We have here the ulna, the radio. This is the interosseous membrane, which goes to the entire length of the radius, between radius and ulna, with its role of stabilization. These are the ligaments with the carpal bone system. We have here the carpal joints. As you can see now, this is an important structure. We have the carpal tunnel. It is at the level of the radiocarpian joint. So we have the anterior, the flexor retinaculum, which is, I will show you right away. This is the retinaculum flexor. In posterior, we have the extensor retinaculum, but the real carpian tunnel is between this flexor retinaculum ligament. In the back, we have the carpal bones. So this is the tunnel. And what is important that through this tunnel, we have the flexor tendons and the median nerve. This is an important structure. It's very important because if there are some carpal bones fractures or rheumatic arthritis or other rheumatic disease or lame trauma, old trauma, the pressure, because of the scar effect, the pressure in this tunnel will be at a high level, and then it will be some sensitive nervous problems because of the compression of the median nerve, and then we'll have the carpal tunnel syndrome. It's a disease, but we will talk later in another session. Now, we will try to go and talk about the tendons. So we know that we have extensor tendons and flexor tendons. But first of all, we have to understand that these tendons are the continuation of the extrinsic musculature. So what we have to understand about the tendons, that tendons, also flexor or extensor, are extensions of the extrinsic muscles. And extrinsic muscles are those muscles at the level of the forearm of the muscles which make flexion of the digits and of the hand, extension of the digits and of the hand, and also laterality of the hand. So, for example, here we have the flexor muscles. There are two layers of muscles. Here we can observe also the tendons. The tendons which are going until the digits. The tendons who are part of them, the flexor tendons, move the digits in flexion, and the part of tendons make the flexion at the level of the wrist. And here we have the first layer, the superficial layer. Here we have the brachioradial muscle. And most importantly, here we have flexor carpi radialis muscle. Here we have flexor digitorum superficialis muscle. This flexor digitorum superficialis muscle give tendons through the digits from second to fifth. Make the flexion, the superficial flexion, as we see, we have four. For the digit, we have four tendons: superficial, profound tendons. Here we have the palmaris longus tendon, which in 10%, about 10% of the population is missing, which is not something very important. You can see it here. If you make this movement, you can palpate it here, the palmaris longus tendon. And we have flexor carpi ulnaris muscle. Yes. Okay, here we have closer to the brachioradialis, and then we can see the profound layer, which is also very important. Here we have flexor digitorum profundus, are going until the end of the digits, of the second until fifth. Here we have the flexor pollicis longus, goes there, and also for the digits, these are the main muscles and the main tendons. And now, if we return to the tendons, all right, so we can see in this picture what I told you. Here we have superficial tendons and profound tendons. And here we have, for example, pollicis longus tendon. As you can see, here are some bursa or sheaths of the tendons. As we told you later. Sorry. Another important thing about the flexor tendons is that at the level of the digit, the superficial tendons are inserted at the level of the distal first phalanx. Here we are. And 2 points. 1 point at the lateral side, 1 point at the medial side, right here. And the profound flexor superficialis go through the insertions of the superficial flexor tendon and go straight to the bottom, to the basis of the third phalanx. So this is very, very important to understand the mechanical of the tendon as well. Another important structures are these pulleys. Pulleys, în română se numesc scripeți și ajută ca în momentul în care se produce flexia să nu existe efect de arc al tendoanelor flexoare, cele două. Aceștia se numesc scripeți sau pulleys și unii sunt încrucișați, cei notați cu C, alții sunt anulari, cei notați cu A. As se revizuie anatomia. So here we have those pulleys which prevent the flexor tendons to provoke a bow effect during the flexion. So we have two types of pulleys, annular types and cruciate types. As you can see when you review your anatomy as well, they are present also at the level of the thumb. Okay. Regarding the extensor muscles and of course the extensor tendons, here we have extensor muscles of the forearm, which gives the extensor tendons for the digits. So it's important. Here we have extensor carpi ulnaris, we have extensor digitorum communis, which go to digits, second, so fifth digit. Then we have here extensor carpi radialis brevis, okay. We have here extensor digitoris communis, as I said to you, and then here we have the retinaculum, the extensor tendons. Then here we have tendon extensor digiti minimi, and here we have tender extensor first digit. So the second digit, so the second digit and the fifth digit, there's a difference between them and the third and the fourth, regarding the fact that the second and the fifth have not only the common extensor digitalis tendon, but they have the proprium, the proper extensor tendons. Deci, deosebirea ca și tendoane extensoare, avem extensorii mușchi, extensor unei degetelor care merg de la degetele 2 până la degetul 5. Excepție și diferența o fac faptul că degetul 5 și degetul 5 au fiecare și câte un extensor propriu. În regulă, ok. At the level of the thumb, here we have extensor pollicis longus and extensor pollicis brevis. So we have extensor pollicis longus and extensor pollicis brevis. These two tendons form here, as you can see, when we make the extension of the thumb on the adduction of the thumb, we can see here the two tendons, and the space between them is forms the anatomic tabachera. Deci, când facem extensia policului și aducția lui, se văd cele două tendoane, respectiv lungul și scurtul, extensor de police, extensor lung de police, extensor scurt de police. Între ele este un spațiu care se numește tabachera anatomică. And here we are in the anatomic tabachera. We can palpate carefully the radial artery. Aici putem palpa cu grijă arteria radială. Se poate palpa în cele mai multe cazuri. And here we have like this. So extensor pollicis brevis makes the extension like this, and extensor pollicis longus make the extension of the second or distal phalanx of the thumb. Deci, extensorul digital face mișcarea asta, extensia falangei proximale, iar cel lung face extensia falangei 2 sau falangei distale a policiului. Here we are at the level of the digits. We have an extensor apparatus, like here in the picture, and here we have the extensor apparatus formed by a lateral band, two lateral bands at the level of the second of the intermediate phalanx, and one medial band. These medial bands end at the level of the medial phalanx, and then it continues those two lateral bands of the tendon. As you can see here, the lateral bands are going and join together at the basis of the second phalanx. So the first movement of the extension is made like this, is made by the medial central slip of the tendon, the medial band of central slip, which end at the level of the second phalanx, here at the basis. This is the first movement, together with the lumbrical muscle. as you can see here, which lumbrical muscles or intrinsic muscles, because they are all the all the muscle at the level of the hands. They are intrinsic muscles, and the flexor and extensor of the forearm are extrinsic muscles. Deci avem musculatura extrinsecă, extensoare, flexoare antebrațului, musculatura intrinsecă, toată musculatura de la nivelul mâinii, care se vede aici. Deci prima mișcare de extensie este făcută de bandeleta medie și de mușchii lumbricali, o parte, iar extensia completă este făcută de bandeletele laterale care se unesc aici. De aceea o să vedem mai departe în patologie, că în momentul în care avem o ruptură de tendon extensor, care de obicei, de aparat extensor, care ruptură, subliniez ruptură, se produce la nivelul bazei falangei 3, adică aici, aspectul este de deget cu vârful căzut sau deget înciocan se mai numește. So, the first part of the extension is made by the central slip here, and by the lumbrical muscle, and the full extension is made by the junction of the lateral bands here at the level of the base of the distal phalanx. So, in pathology, when we have a rupture of the distal insertion of the extensor apparatus at the level of the distal phalanx, we have see this aspect of the digit with the distal phalanx. It's dropped down because the rupture here, and this is the aspect of the mallet finger. Okay. Alright, so when we check the hand and we try to develop the examination for the tendons, for example, as I said before, at the inspection you can ask the patient to do flexion on the extension of the hand, and then you will see if the tendons are in good shape. Or when you see a digit like this, digits like this, or digit like this, or like this, then there's a loss of equilibrium between extension system and flexion system. So, for example, if we have a flexor tendon injury, we have a little more extended in the relaxed position of the digit or of the digits. And when we have extensor tendons injured, then the equilibrium tends to go to the flexion, as we can see here. Otherwise, to check the tendon which are injured, we can simply refer to anatomy. If we have, for example, an injury here or here, I mean starting distally from the third medial part of the forearm, we can have flexor tendons cut here, superficial or profound or both of them. So if we check the superficial tendons, simply block the interphalangeal distal joint and we put the patient to perform the extension. If he can do the extension, it means that the superficial tendon, which is inserted here at the basis of the second phalanx, it's not cut, so it's functional. Otherwise, if we want to check the profound tendons which are inserted at the base of the distal phalanx, we block all the joints except the distal interphalangeal joint and ask the patient to do the flexion of the distal phalanx. If he can do the flexion, then the profound tendons are okay, are not injured. If he cannot do flexion from of the distal phalanx, then there is an injury regarding the profound tendon. Of course, at the level of the palmar region, the same thing. At the level of the digit, the first phalanx, the same thing. But if we have in this zone, starting from the middle intermediate phalanx further, then here we can have only profound tendon injury. The same thing, and of course we can see trauma, a wound here or here at the level of the flexor retinaculum, here the palmar lever, or here. Regarding the thumb, here we have, of course, we can have to check the tendon, flexor tendons longus. Okay. Here the same thing. We can ask the patient to do active extension, and of course the extension like this, starting from the level of the table. Regarding the thumb, we can see if there is any lesion. We can see that there is the lesion of the extensor pollicis longus. The patient cannot do the extension from the level of the distal phalanx. And also, if there is the brevis, the extensor pollicis brevis, the short part of the extensor tendon of the thumb, he cannot do very good the extension. Only he can do he cannot do like this, the extension from here, but only he maybe can do the adduction of the thumb. As I already told you, there are some shades of the tendons which are marked with blue here in the anatomy drawings. Here we have the common flexor shed or ulnar bursa. Here we have the synovial tendon shed of the fingers, and here we have the tendinous shed of flexor pollicis longus. This is very important for the nutrition of the tendons and also for the drainage of the synovial liquid. As we can see later, there is also an infectious pathology of these sheds. It's called tenosynovitis, but we will talk about it at the right time. Also, we have here also for the extensor tendons. We can see here with the blue ones, there are 5 compartments regarding these shades. I think it's correct. The spelling, I don't know if it's correct, but I hope it's correct. So we have the intrinsic muscles. There are 19 muscles, intrinsic muscles. We have the tenar region or the lateral region. We have the medial region, and we have the hypotenar region or medial region. We have the tenar region with a lot of muscles. We have 2 planes, superficial and profound, as you can see here in this presentation. I will not insist about them because you will read it home in the anatomy atlas. We have lumbrical muscles in the medial regions. I told you also about them. There are 4. They are laterally and medially inserted laterally and medially of the flexor profound tendons. There are also 7 interosseous muscles, 3 at the anterior level and 4 at the dorsal level. They are placed in interosseous spaces between metacarpal bones, so intermetacarpal bone spaces 2, 3, and 4. And we can see a breathing action of these intrinsic muscles here. So the tenar region, the abduction of thumb, rotation of first metacarp. We have also a hypotenar region. We have the abduction. Okay, abduction. This is abduction of the fifth digit, the flexion of the proximal phalanx of the first digit, and anterolateral attraction of 5 metacarpal. And the lumbrical and interosseous muscles, the intrinsic muscles of the medial region, and they have complementary flexion and extension movements, and also abduction and adduction of the fingers. The vascularization of the hand, we have the radial artery and the ulnar artery, as you can see here, the radial artery and the ulnar artery. They are terminal branches of the brachial artery, right here. We have also going through and the level of the palm, and they form two arches, two arterial arches, profound and superficial artery arches of the hand. From these arches, the common digital arteries start here, and at the level of the metacarpophalangeal joints, the common digital arteries split in proprium digital arteries, propral-palmar digital arteries, as you can see here. Here, palmar arches, common digital arteries, proper digital arteries. Here and here is the radial artery, here is the ulnar artery. Right? How can we examine the arterial system of the forearm and of the hand? It is very simple. First of all, the color of the skin is very important, because the color can tell us, especially in the traumatic context, when do we have ischemia, and if we have ischemia, we have a pale color of the skin, and then when we have the venostasis, then we have a blue aspect of the skin. Also, we can see the superficial veins. The superficial veins you can see here, the dorsal of the hand and of the forearm, and also we can see the anterior aspect of the forearm. We can see the main venous drainage, which is formed by cephalic vein and basilic vein, cephalic vein and basilic vein. Regarding the circulation, we can observe the color of the skin. We can palpate the radial artery here, always with 2 or 3 fingers. We can also palpate the ulnar artery here. Sometimes we can palpate in the anatomic tabachere here. We can palpate also the radial artery, which goes right here in this traject under the extensor palmaris lumboris here, and go profound to the palm and form together with the ulnar artery the palmar arch. Also, we can observe the veins, the superficial veins, if they are or aren't permeable. And also we can see if they are active. Putem vedea dacă se umplu. Okay, so they are permeable. And the color, there are no differences of color. We have pulse in the radial, we have pulse in the ulnar artery. Sometimes we can touch and we can feel the pulse, also the proper digital arteries sometimes. Also we can check the capillarity function of the digits. We can see here if we have good function of the capillary system. Putem vedea reumperea capilară dacă este corectă și dacă este rapidă. Now we can continue with the innervation of the hand. We have the three nerves: radial nerve, ulnar nerve, and median nerve. As you can see here, we have a lot of branches of the main nerves, which they are mixed nerves. They have motor and sensitive components. But what is important at the level of the hand is the sensitivity. It's very important. And here we can see the dermatomes or the sensitive zones in function for the different nerves. So here we have the posterior aspect of the hand, and we have here with this color, cyano color, I don't know how to say it, culoare mauve, este nervul radial, so this is the part of the radial nerve. Here we have the part with the blue of the ulnar nerve, and with the yellow median nerve. This is the posterior aspect of the hand. Here we are. And at the level of the palm, we can see mainly the sensitive part is covered by the median nerve, and then we have the ulnar nerve, the blue part, the half part, the lateral half part, the medial part of the fourth digit and the entire fifth digit. And here we have, of course, radial. Here we go again, the posterior aspect. And it is very important to know these areas to define during the examination if there is a normal sensitivity or is a low sensitivity or there is no sensitivity. Este foarte important de știut aceste dermatome. Așa se numesc zone de inervație senzitivă a celor trei nervi împărțite pe zone, cu galben medianul, cu albastru ulnarul, cu mov este radialul, asta pe partea anterioară sau palmare și pe partea posterioară la fel. Este important să știm aceste zone pentru că în momentul în care facem examinarea senzitivă, dar la nivelul tegumentului, să știm dacă avem o senzitivitate bună sau o senzitivitate scăzută sau anestezie în diverse zone și să știm fiecare zonă de care nerv aparține ca și senzitivitate. Of course, there are also motor components. So you can see here, for example, we have the radial nerve, the motor part of the radial nerve is about the extension and adduction of the hand, and also supination and abduction of the thumb. We have also ulnar nerve. We have, this is the main motor nerve of the hand. It makes the flexion and the adduction, the flexion and the adduction of the hand, abduction and adduction of the digits, adduction of the thumb, the distal phalanx flexion of the fourth and fifth digit, and the flexion of the first phalanx of the thumb. So we can see in time in another session when we have the high trauma of one nerve. The motor part of the nerve will give a specific aspect of the hand. For example, when we have the ulnar nerve cut at the higher level, where the motor part is main important, then we have this aspect of ulnar grief. Yes, for example, because, as we said, it makes the flexion and the flexion of the fourth and fifth digit. And if we have this kind of lesion, then there are a lot of motor function that are blocked, are impossible to make, but we'll talk about it later. Okay. So why it is important to know the dermatomes? Because we can check the sensitivity of the hand. The soft level, we ask the patient to close the eyes and turn the head on the other side, just to be sure he will not cheat. And we can check the sensitivity and see if there is the same sensitivity. If we have, for example, a lesion at the level of palm or at the level of the forearm, yes, we can check the sensitivity. And if, for example, if we have anesthesia of this part of the medial part, which is sensitive, generated by the median, if we have hypo or anesthesia, then we can be pretty sure that through this wound the median nerve is partially or totally cut, and so on. The same thing for the ulnar part and the same thing for the radial part. For example, if we have here on the trajectory of the sensitive part of the radial nerve, if we have a wound, then we can suspect sensitive radial lesion. And if in this zone on the posterior and here, if we have hypoanesthesia, then we can be pretty sure that here we have cut the sensitive part of the radial nerve. And of course, the surgical exploration of the wound, we can see if we were right or not. So it's enough for this week. Stay home, read a lot of medicine, plastic surgery, read a lot of everything about news, and stay home and safe. Check out the internet for informations, for medical informations, for your study, for plastic surgery. Check out for anatomy, review the anatomy, read everything you want and everything you need to know, and don't forget to ask questions. See you next week.